Hi, everybody. In case you're just joining, I'm Rita. I'm a family doctor, an assistant professor at UBC in the Department of Family Practice, and I'm presenting with my longtime Let's Think Critically About Medications colleague, Wade Thompson. Wade, can you say a few words about who you are?
Yeah, sure. So I'm a pharmacist. I work in long-term care now. I've worked also for a number of years in primary care in Ontario, and I'm an assistant professor at UBC in the Faculty of Medicine.
Great, thanks. Okay, and we are going to share our declaration of conflicts of interest, which no surprise, I don't accept any funds from pharmaceutical agencies or industry. I get money for research from various sources, for which I'm extremely grateful. And I get paid by the University of British Columbia. And as a family doctor, I get paid on the new longitudinal family practice program. And wait.
Yeah, so I also don't have any relationships with industry. I get a small honoraria for writing an article about deprescribing in a pharmacy magazine. And I also have grant support from a few different places, and I get paid by UBC as a faculty member and by Fraser Health as a pharmacist, even though I work in Providence Health. It's very interesting.
Yeah, so I think both Wade and I like to be as transparent as possible about where things come from. We know that everybody has bias, every human has bias, and if they say they don't have bias, their insight is impaired. So we try to acknowledge where things are coming from, and have really paid attention to the literature that shows that even small gifts such as sandwiches can influence your decision-making about prescribing. So anyway, without further ado, it looks like there are many people who really want to talk about sleep medications. This might be a little bit of a group therapy session, as well as a sharing of a review of the evidence. So we want to talk about the evidence for sleep medications, apply strategies for cutting back on those medications, and how to talk to people. So both Wade and I have conversations with real life patients all the time, as well as review the literature, because we are nerds and like to do that. All right. First case, Mr. Nas just lost his job and he can't sleep. He's well known to me. He's 48. He's an active person. His BMI is 24, acknowledging BMI as a very controversial tool, but whatever, we're not talking about that here today. No substance use. He's got a blood pressure that doesn't make anybody get too excited. He has no regular medications. He has no history of insomnia, and he's an engineer at a small firm that just closed. And he reports that he has not slept for 6 days. All right, so this is not a real patient, but a conglomeration of patients that I have seen in my office over the last 15 years. And so we're going to do the usual thing. We're going to get the history and do an exam and try to take an approach. We have developed a couple of tools that we are happy for you to take advantage of. So one of my obsessive compulsive things that I do is I write preposterous templates of SOAP notes that include absolutely everything, including evidence citations. And so I've done so for this presentation. And on the next slide, I'll share the link where you can go and download that as a PDF if you'd like. We're going to be talking about one tool for assessing insomnia, which is the Insomnia Severity Index. And that is the link to that tool is right there. So we want to get all the details about his sleep. We want to know how often is he awakening? How often does he stay awake? How often does he need to go to the bathroom? For a 48-year-old man, that can be really important. Maybe it's not insomnia. Maybe there's something else going on. What's his usual bedtime? How long does he wait out? How long does it take before he falls asleep? What time does he get up in the morning? What time does he want to get up in the morning? Does he nap during the day? And nap length. So that's all the stuff that we want to know about sleep. And the insomnia severity tool does a nice job of collecting that. This is where the SOAP note is. It's on my website, and then this weird media underscore file 6080. But if you just go to my website, you'll be able to find it in the resources section if you are interested. Okay, so this is what the insomnia severity index looks like if you haven't seen it before. And so when we give it to Mr. Nas, we get a score of 12. So it turns out that he's having a really hard time falling asleep, but once he gets asleep, it's okay. And maybe like he sometimes wakes up too early. He's very dissatisfied, or sorry, he's dissatisfied, not quite very dissatisfied with his sleep pattern. It's unusual for him, and he's feeling really upset about it. When I ask him this, he realizes, well, it's not really affecting my life too much, other than I'm thinking about it all the time. I'm worried about it, question 6. And it's not really interfering with his daily life. So he's not falling asleep. He's not needing a nap. He's able to attend to his tasks once he's up. So the scoring here says that he's got, like, maybe he has insomnia, subthreshold. So the tool helps us. It doesn't give us anything super specific other than say this: if he has insomnia, it's not super terrible. All right. So as I hinted at, we want to make sure that we are checking all the other things that need to be checked. Red flags, so the usuals, night sweats, unintentional weight loss, thoughts of self-harm. So we really want to make sure that that is not happening here, which fortunately for Mr. Nas, it is not. So we then want to talk about how this sleep issue is affecting his function. And this is the bread and butter of family medicine here, primary care. Is he feeling like he has reduced attention? Is his family life falling apart because of his sleep? Is he increasingly irritable? Is he sleepy? Is his motivation and energy? Does he think that he's having, is he more clumsy? Has he had a car accident? And then a little bit more of the red flags here. Does he have some hyperactivity, impulsivity, or aggression that's happening? And then, insomnia, it's not super straightforward. It is very complex, which is probably why we have so many people here in this session today. And so you really want to be thinking about comorbidities. And this is where a longitudinal relationship in primary care can really be a gift when discussing insomnia. So you're going to know if you don't remember as soon as you walk into the room and see him, you're going to have it in his chart about anxiety, depression, a previous adjustment disorder, substance use disorders, any of PTSD, bipolar, eating disorders, etc. Does he have sleep apnea? Has that been diagnosed before? Does he have restless leg syndrome? Does he have BPH that is causing him to pee all the time? And then there's all kinds of other diseases that can affect your sleep as well. A partial list of which is on the side here. So, it's multifactorial. You've got life stages, you've got what's happening in the world. And so it is complex, and we need to be considering all of this about this person in front of us before we even get to what is the evidence for the medications. So let's talk about other medications that might be causing some problems. So is he taking ADHD medications? Is he taking a stimulant? Is the timing of that potentially changed recently? Is he taking any sedatives or opioids that could be disrupting his sleep pattern? Bronchodilators, asthma medications, Ventolin can be notoriously stimulating. Additional other breathing medications can have effects on sleep patterns, antidepressants, diuretics, and other steroid products. So we need to get all of that stuff out. And again, within a longitudinal relationship, either as a pharmacist, nurse practitioner, or a family doctor, you probably have this to hand. And otherwise, this is something that should be, if you don't have this to hand, this is something that should be considered definitely before a prescription. In terms of the exam for a patient presenting with insomnia, there's not much really. If I know this patient and I come in and their like hair's all rumpled and their clothes have food on them, and I realize that this is a very different picture, that's very helpful to me. But appearance doesn't always tell us very much, as we know. You can't judge a book by its cover. Knowing what his blood pressure is helpful, and having the insomnia severity index score. There's no routine labs recommended for presentation of insomnia, but based on your patient, you might be considering looking at their thyroid, maybe the renal function, maybe some iron studies, maybe A1C. So all of those things related to the comorbidities. Your differential diagnosis, maybe Mr. Nas does have insomnia, or maybe this is an adjustment disorder with some perseverative thoughts about sleep. Maybe this is a new onset of depression. For him, it's probably not a medication effect because we're not prescribing him anything else. But for other patients, it might be, or there could be a comorbidity exacerbation. So really important to think about that differential for each patient that you're presenting. I find with insomnia that it's really important that I connect with the patient about what they're worrying about and what their hopes. I have a number of patients who are convinced that they will die if they don't get 7 hours of sleep, which has taken me a little while to kind of figure out that. And I'm laughing because any new parent knows that you don't actually die from not getting 7 hours of contiguous sleep. And many of these people were parents at some point, but they've kind of forgotten that. So there is these pervasive societal messages about what sleep is needed. And occasionally there'll be a headline on the New York Times or the Globe about the connection between sleep deprivation and dementia that can get people really worried. And when they're already worried about something, that can really get attached. So pulling those things apart can be really helpful. All right, so let's go back to Slido. And what do you folks think? This lovely person with whom I have a longitudinal relationship with, who has had this major life event, should we give him some sleeping pills? Is that the right answer for him?
Okay, have a mix here. So you have 8% saying sleeping pills are never a good idea. Around half of people are saying that he doesn't really meet the diagnostic criteria. And then we have 20% saying he needs to rest. So yes. And then about 15% saying, I don't know. And then a small portion of people saying to do something else. So
okay, great.
As it is. But most people are saying no.
Okay, most people are saying no. It's a TI conference, so we expect that. And of course, it's very complex and it's not easy to answer in a multiple choice question. Yeah. And so we are going to take a look at the evidence. I'm going to hand things over to Wade here.
Awesome. So yeah, so I think, so Rita talked about a lot of things that we probably want to do first before we get to the point of even considering a medication. So thinking about underlying causes, addressing potential medication contributors. I think that's hopefully not probably news to anyone, but we may be thinking about whether a sleep medication might be a good option. And then, of course, as part of that decision, together with the patient, we want to be thinking about the benefits and the harms of those different options that are available, of which there are numerous, as we'll see. And I think like the name of the game is really just is having realistic expectations, thinking about what the goals are. Like Rita talked about, there are a number of different things to think about: falling asleep faster, staying asleep. Maybe the daytime function is really impaired. So thinking about what we're trying to achieve and how likely we are to do that. And the reality is, kind of at the bottom line, is that for medications that have official indications for insomnia, the benefits are usually relatively small and the chance of benefit is around the same as the chance of harm. And we'll talk more about numbers in the coming slides. And the other thing to think about is that for off-label medications and an alternative to benzodiazepines, the evidence really is non-existent, or it's quite uncertain, but there is known potential for harm. So that's kind of the underlying message, but we'll get down into some of the numbers now. So you can go to the next slide. And so we'll be talking about the individual medications and medication classes pretty quickly, but a very comprehensive overview of the evidence was published last year in Lancet, which is available open access, I believe. And so it's a huge systematic review and network meta-analysis. And then the other thing I would point out is people are talking about resources. So maybe people are aware, maybe people aren't aware. The Provincial Academic Detailing Service in BC has an amazing resource for insomnia that covers a lot of the material I'm going to talk about, which is of course free. And then the RX Files drug comparison charts have a really nice section on insomnia that again goes through a lot of the same stuff I'm going to be talking about. So those are two really good resources, and I use them all the time in my own practice, so really helpful. So a lot of what I'm talking about is coming from these places. We can go to the next slide. So we'll just again kind of get a sense of where people's kind of heads are at with sleep medication. So how much longer on average do people taking zopiclone sleep in a night compared to placebo? There's a few different options there. All right, so we got, so I think people seem to be in the ballpark. Most people are saying either 30 or 15 minutes, and a few people are saying 60 minutes. So we'll go to the next slide and just kind of look at the numbers a little bit more. So again, we really today just are hoping to give kind of a realistic picture and some numbers that can be useful in talking to patients about sleep medications. And again, just setting realistic expectations for patients and for ourselves. We'll talk about number needed to treat and number needed to harm. And really these reflect just the proportion of patients in trials that were reported some improvement or reported one or more different harms. So from the slide that I just went over with the Slido question, I'm guessing this is not news to people, but the number needed to treat for benzodiazepines and Z drugs is around 10 to 15. So the chance of a person benefiting is around 1 in 10 or maybe even a little bit higher. And when you break it down, you can see, again, smaller, modest improvements. So falling asleep a few minutes faster per night, being awake about 15 or 20 minutes less per night, and then sleeping around half an hour more in a night. So most people were, again, in the ballpark. And I think, again, it's important to be aware of the modesty of the benefit. And then the harms, you can see the chance of harm is about the same as the chance of benefits, which is important. And when we think about harms, we know probably that there's next day fatigue, there's also cognitive impairment, dizziness, and then there's associations with things like motor vehicle accidents and falls and fractures. So those things are going to be quite important harms to be aware of for people. The other thing with benzodiazepines in particular is that tolerance develops really fast. So we're talking like in as little as 7 days. And that's particularly to the sleep promoting effects. So you lose benefit quite quickly, but the side effects, the things like cognitive impairment, next day fatigue, persist long term. So you lose benefit, but you continue to have harm. And then in terms of the benefit, there's no evidence of benefit beyond four weeks. So that's why you see a lot of recommendations saying if you use them very short term. With Z drugs, there is a little bit of long-term efficacy evidence. So with S-zopiclone, there are trials that go out to 6 months. So a little bit of longer-term evidence of benefit there. But I think get into the differences between agents, but I think the bottom line is that whether there's any clinically meaningful benefit between any of these benzodiazepines and Z drugs is unlikely. So I think the general consensus in the literature is that benzodiazepines and Z drugs have similar magnitudes of benefit, similar magnitudes of harm. So I think that's something else to be aware of. So we can go to the next slide. And so the next question is another Slido question about lemborexant, or the trade name Dayvigo. So just trying to get a sense of whether people have come across this in their practice. Okay, so that's about a 50-50 split. And just getting a question about S-opiclone having a lingering aftertaste of opiclone. Yes, S-opiclone also has an aftertaste, just to quickly address that question. So we've got a 50-50 split on people having come across lemborexant. I have come across it like once or twice, so very rarely. So we'll go to the next slide and just kind of take a look at the evidence behind lemborexant. So this is coming from a few meta-analyses and from that network meta-analysis I talked about in Lancet. So we can see for lemborexant, the chance of benefit is similar to benzodiazepines or Z drugs. So the number needed to treat is in the same range. And the benefit is sustained longer term from the clinical trials anyways. There's clinical trial evidence up to 1 year actually. So it does have longer term evidence of benefit compared to Z drugs, but when it comes to the harms, there's much less understanding of what the harms are. So in the longer term trials, there's more dropouts compared to placebo in the same order of what you see with benzodiazepines. And this adverse effect rates are similar to placebo from the trials, but there is increased risk of somnolence and nightmares in particular as two specific side effects. So from available data, seems to be modest benefit, but the safety data is still not well developed. And of course, it's not covered by a lot of insurance plans. So there's that to take into account. And so this is thinking about some of those alternatives to benzodiazepines or Z drugs. And so the next one is about low-dose trazodone. Is it safer than benzodiazepines or Z drugs? Okay, and so we have about, again, a 50-50 split saying yes and no. And then some people are saying, I don't know as well. So we'll go and take a look at some of these off-label medications quickly. And so these are common alternative to benzodiazepines or Z drugs. And I realized as I was making this that doxepin, which is listed up here, is actually has an indication at the low dose, so it's not actually technically off-label. But anyways, low-dose trazodone. So it's been examined in a Cochrane review and in that Lancet meta-analysis that network meta-analysis that I pointed out. So the thing with trazodone is very short-term, like 2-4 week trials. So again, similar to benzos, very short-term evidence. There's 3 small randomized controlled trials, and the Cochrane review said there's low certainty evidence, meaning not really sure if it has any benefit. But from those trials, the number needed to treat compared to benzos and Z drugs is again pretty similar. So it was around 13, but then the number needed to harm is similar to benzodiazepines and Z drugs, and that comes from things like sedation, somnolence, dry mouth, and morning grogginess, so kind of a hangover effect. So the risk of harm is actually quite similar, but there is just much less evidence with trazodone. So I think the conclusion is that it's not uniformly safer than a benzodiazepine or a Z drug. Then we look at some of the other drugs, quetiapine at low doses. There's one RCT that had 13 people in it that showed there was no benefit for insomnia, but there was risk of harms, sedation, urinary retention, and metabolic side effects. So the magnitude of harm is, again, similar to benzodiazepines and Z drugs. Then you have mirtazapine, which has not been studied for insomnia alone, and again, has known risk of harms. When it comes to doxepin, which is available over the counter at low doses, there may be a small benefit in sleep maintenance, but again, in a lot of the reviews that have come out on this, the conclusion is that there's really not a clinically meaningful difference. It may have fewer side effects, but there are potential adverse effects, particularly in older people, related to its anticholinergic properties, and also there's potential for sedation. So there are risks and maybe not, or probably not much benefit in using doxepin. So it's kind of a quick overview of some of these other options, and we can go to the next slide. And so the other two options that you probably commonly see, melatonin and then antihistamines like Gravol or Benadryl. So from that Lancet network meta-analysis, they concluded that there's no clinically meaningful benefit with melatonin compared to placebo. There are a lot of different meta-analyses and systematic reviews on melatonin. Some are reporting benefit, and others suggest no benefit. So it's really quite conflicting. And then there's also limited safety data. Trials generally show similar adverse event rates to placebo, but there is potential for daytime sleepiness and dizziness. So I think there's really not convincing evidence of benefit, and but maybe not as much safety concerns as things like benzos and Z drugs. And then finally, antihistamines like Benadryl and Gravol, 2-week, 1-week trials, no clinically meaningful benefits, but there actually is benefit or evidence that if there is a small benefit, tolerance develops really fast, like 1 or 2 weeks, and it comes with tons of side effects, particularly in older adults, like dried mouth, or potential for orthostatic hypotension, grogginess. So not a good option, the antihistamine. So that's like a quick tour of the different pharmacological options. I'll pass it back to Rita to talk about CBT.
Great. And I noticed there's a question about information in the pediatric population, and we reviewed the evidence for adults. And I would say in general, pediatric population less well studied, and the limitations of the evidence that we are presenting for adults are almost assuredly applicable to children, but we are not presenting on that. So let's talk about cognitive-based therapy for insomnia. So this is a short human-led or app-led CBT process that helps people rethink about their sleep. And there's been a lot of studies, and they almost all show a benefit. And the systematic review that I am presenting here, that was published in 2022, shows that there is quite a positive finding from the combination of these studies. Now, is it life-changing for everybody? No, nothing is life-changing for everybody, right? It's all, especially when it comes to insomnia and things that are involving the combination of our mind and body. Very often we're looking for small nudges. Miracles are desired, but nobody has the magic wands. And so I just wanted to acknowledge that there are some caveats to this. So it's great, hey, let's use CBTI for everybody. Very often there's costs. In British Columbia, we do actually have access to some free resources, which I have listed at the end. And there has been minimal study of how to make CBTI applicable to people who are not English speaking and living in North America speaking English. There has been studies done in other countries for people who speak that same language, but the idea of somebody having a different cultural background, there's a lot of complexity around this, and we don't really know how it works. In addition, the social determinants of health have not really been explored. So, you can ask somebody to think differently about how they sleep, but if they are sleeping in a tent and it is raining, let us not imagine that that is really going to be that helpful. We are going to talk about applying evidence to patients with some shared decision-making. So let's go back to Mr. Noz, or Mr. Nosy, the gentleman who lost his job and presents saying that he hasn't slept in 6 days. So honestly, there's a couple of different ways that I would present this. And I think Wade and I really felt strongly that we wanted to talk about reality. It's a nice idea to think that you can have this binary, yes, you should prescribe, no, you shouldn't prescribe. But that, of course, is not the case for most human interactions that you have in primary care. And so one option might be to reassure him that this is a very difficult situation in his life. It looks like his body is getting enough sleep, and provide him some education about what he might do to modify his sleep, or what he might expect for the changes in his sleep over the next couple of weeks, which is that if this is an adjustment disorder, we would see that in the first couple of weeks, the sleep disruption is the most significant, and then we would see some improvement. If he were to develop more pervasive symptoms of depression, that would be a great indication for him to come back and check it back in with us. If the sleep issue continues beyond the next week or so, come on back in. Let's talk about it. Let's talk about what else is going on and set that follow-up specifically. Similarly, have I prescribed in situations like this? Absolutely, I have in some situations. And it's a very similar approach. So I provide the education about what we can reasonably expect. I set the expectation that we are going to use this for short term, because that's what the evidence is that we have it. We're going to use the lowest dose that might be meaningful, and what the potential harms are, and what my personal expectation is around a refill pattern, which is not really. And so do I have some people that are on long-term sleeping pill medications? Yes, we're going to talk about that at the end of the session. But here's an example of a short-term prescription that I might provide in a situation like this: 3.5 milligrams QHS-PRN. And I will very often set people up to say, okay, so you've got all this information now, let's try to do it without the pills. Maybe you want to just have those pills right next to your bed as kind of a security blanket. If you can't fall asleep within, this amount of time, I usually suggest between 20 and 30 minutes of you lying down, then maybe you get up and you try one more time, or you take a tablet at that time and you see what the benefits are. So I'm going to skip over this case, Wade, and go on to the next section, I think. We've got a pretty straightforward case here of somebody who got started sleeping pills in the hospital, and they probably didn't need them, and then they just show up to get them refilled, and they're happy to not get them refilled, which fortunately doesn't happen as much as it used to. And if in the discussion period we want to come back to this particular kind of case, happy to do that. So let's jump to everybody's favorite patient, the one who shows up on your panel who's been taking sleeping medications for 7 years.
So yeah, long-term prescriptions. And I think the name of the game here, as with initiating sleep medications, is to kind of be realistic. And so we'll try to keep to that kind of central tenet as we go through this case. And in this case, you have a 74-year-old woman who is requesting a refill for lorazepam, who's on a number of different medications and has a history of osteoarthritis and hypertension and anxiety. Relatively new to your practice, and you don't really know her quite well, or that well yet, but she came to you already on this medication, and today is asking for a refill, and doesn't really have any other clinical issues other than this refill. So we can go on to the next slide. And so, knowing this information and the circumstances, we might have a few different ways of approaching this situation. So we might want to just do the refill, or if you're a pharmacist, request the refill. We might want to hear a little bit more about her insomnia and go from there. We might want to give her some quick education, share our concern, and then maybe revisit in the future, or we might want to try to get right down to deprescribing right away. So I think we have a slide out question here. We're just kind of wanted to see what people tend to do in a situation like this. So if people want to just go ahead and vote, most or the biggest proportion of people, 50%, are saying they share concern, provide education. People want to get more information about her insomnia history, and then a small portion would recommend deprescribing today. And about 1 in 5 people would revisit in the future. So that's I think probably kind of where our heads are at too, I would say. So we'll go on to the next slide then. And so I think, I mean, my approach in a situation like this, but I'm not saying it's the approach, but getting more information, especially if there's no other pressing issues, is a good starting point. And it's really similar to gathering information for when you're thinking about starting a medication, is just to understand the sleep a little bit. And in this context, to get some history with the medication use, like how long has she been on it? What else has she tried? What was her response to the lorazepam, if she can remember? Has she ever had any adverse effects? Is she concerned about future adverse effects? And then we also want to be thinking about, are there any potential medication or sleep hygiene related contributors to the sleep problems that we might be able to address? And that's really going to inform our approach. And again, this is just kind of a conversation, like just wanting to get a little bit more information. And that's really going to help us. So if we're thinking about getting that history, we might find out that she's been taking her lorazepam for about 20 years. She's saying it's her whole life. And we find out that she was feeling really anxious at one point when she was going through a rocky patch in her marriage, and it really helped her sleep. And her old doctor at one point, though, told her, you need to come off this, it's not safe, and gave her a prescription for 1 milligram of lorazepam. And she had horrible sleep and just felt awful for a few days. And then she just went right back to her old dose. And a few years ago, she started taking melatonin. She doesn't really think it does anything, but she's kept taking it. And then you find a little bit more information about her sleep. She's not sleeping terribly. She gets us around 6 or 7 hours of sleep a night. She feels pretty rested in the day. But she said lately she's feeling a little bit dizzy when she stands. She doesn't know what that's related to. And you also find out she drinks coffee until about 3 and takes a nap. So these kind of are just some things to think about as we kind of work through the case. And so we might choose the approach of sharing concern and providing education, which I think many people would want to do. And I just highlighted one resource up here, but there will be a few more in the coming slides. So the Canadian Deprescribing Network has some educational materials that highlight some of the issues related to sedative medications, benzodiazepines in particular. And in my conversations that I've had with people like in this case, sometimes people in the past were just said, you need to be off of this medication. They weren't really told why. And there hasn't really been much of a conversation with trying to understand where the patient's coming from. And they have a bad experience and they're really cautious about coming off of it. So that's a big starting point, is to help share the rationale for why deprescribing might be considered, and just offering it in an open way, and providing some education about the risks of benzodiazepines. And then thinking about other things like sleep hygiene, which is being talked about in the chat, and also realistic expectations of sleep, which is also something that's being raised in the chat. And again, we'll show some more resources later. And so there's a lot of evidence about deprescribing benzodiazepines, and we've probably all been bombarded, and I have bombarded in the past, and I've come to a much more moderate place now at this point. The evidence ranges from really intensive things like, CBT multiple times per week, and daily check-ins to support people tapering. And then there's, on the far end of the spectrum, more pragmatic approaches like providing education in the form of pamphlets or brochures like the ones I just highlighted on the previous slide. And I think it's good to be realistic about what's possible in practice, and kind of what's practical, and just the reality of long-term benzodiazepine use. If you look at the trials of the more pragmatic approaches, the success rates at 6 months or a year are about 25%, or 1 in 4. So most people are not going to come off of their benzodiazepines when offered some education, but some motivated people might, and you might come back to the conversation later on. As you get more intensive, the success rates go higher, kind of like smoking cessation. But even with very intensive interventions, the success rate is like 60% of patients, and that's probably not something that's realistic in practice. So again, provide the education, be realistic that some people are going to prefer to stay on their benzodiazepines long term, but some people may have not actually heard a lot about the long-term harms or any of the harms or tolerance and things like that. So providing education is a great starting point. And I think, again, one of the biggest things is just start the conversation, see where people's heads are at. We're not going to be pushing too hard. Some interesting research is being done in the last couple of years, trying to understand like how to start the conversation and what kind of things really speak to patients. And so there's this interesting study coming out of the US where they interviewed patients who are on benzodiazepines and asked them like, what would motivate you to deprescribe or consider deprescribing. And one of the biggest things is that people are more responsive to information about harms. So if you look at some of the phrases on here, these were things that people really responded to more than things like, oh, you don't need to be on this anymore. It's, we're concerned about side effects and the potential for harm. That tends to gain buy-in more. So I just put some conversation points up here that were shown to be preferred by patients in some of the research. And again, not everyone's going to respond to this, but it's just more people may be responsive to information about harms. And yeah, in the vein of kind of keeping things open, we always want to understand where people are coming from and to integrate their experiences and preferences into talking about the options and developing a plan. So again, we might just ask, what have you heard about the side effects of benzodiazepines, and how do you feel about that? Or why are you concerned about stopping, to kind of understand and be able to have the conversation? And if people are interested, what is the goal? Do they want to stop completely? Do they just want to lower the dose? Do they want to, feel better during the daytime? Things like that. So kind of having a starting point that you can both agree on. And then if they want to consider tapering or reducing the dose, how fast do you want to do it? It's important to get the patient's preferences for those kind of things. And I've highlighted some resources there which can provide insight and have some and help with conversations. Well, I guess actually, so the other thing I would say in some of these resources is just also having expectations around if you reduce the dose, what to expect, what to watch out for. And I think people also like to know that they can return to the previous dose or pause the taper and that it's just kind of a trial. It's not like you're going to be off of this forever or you're going to be on this low dose forever. Is that you can be kind of responsive and see how things go. So that's also something to keep in mind. And yeah, so just to highlight some resources here that have some really good information. The Center for Effective Practice in Ontario has a nice package, and that's at the bottom of the slide here, which talks about starting sleep medications and deprescribing, so kind of the whole continuum. And then there's a lot of good information about sleep hygiene and stuff like that in the Sleepwell resources, and a lot of free information that's been tested with patients on that website, sleepwell.ca. And we just come back to the case. So I think most people felt, it's reasonable to share a concern, provide some education. Maybe you give a refill for, 1 month or 3 months and offer to revisit in the future. There may also be some sleep hygiene things that could be addressed, like thinking about the caffeine intake, thinking about napping, and seeing whether that maybe gets some improvements in sleep and maybe helps with saying, oh, maybe I don't necessarily need this sleeping pill as much anymore, if I can address those things. And also, again, just trying to understand have the patient understand that we can work at their pace and on their schedule when it comes to deprescribing. So yeah, but this is not the resolution, but a possible resolution, which I think is kind of trying to be realistic about success rates, and how these things kind of go. So yeah, back to you, Rita.
I wanted to say, please add any additional comments and questions into the chat. We'd be delighted to hear from you. And, there's been some great things that have been raised by other participants throughout. So thank you very much. And we just wanted to go back to the questions that we asked at the very beginning. I'd like to get a sense. It looked like most people had a good understanding of what the evidence probably was going to be. But I'd like to see if the resources that we've provided have addressed that. I know where to go for good information, because if they haven't, that's something that Wade and I can take away and potentially respond to you with giving you some more resources about that. So let's just do a quick little quiz. Let's go back there and tell us. So you were already great about doing your history. I'm hoping that we haven't made that worse.
94% people say yes, and 6% still are saying on the maybe, sort of.
Okay, great. It'd be, if you still have questions, please add those to the chat right now. That'd be great. Right. And for the expected harms and benefits of
90% saying yes, 93% saying yes, 7% on the sort of maybe.
Okay, great. Yeah, again, please add your remaining questions. I can explain the evidence of non-pharmacological sleep interventions.
Oh.
Okay, still sort of maybe, which makes sense because it's not as easy as prescribing. Okay, so let's go to the chat here.
So I guess I'll start off with Tracy saying, in the case that I just talked about, the pros in staying, do they outweigh the cons? I'm not saying that. I was saying that the success rate of interventions is, up to like 60 or 70% of patients being able to come off of benzodiazepines if there's an intervention. I don't think we're saying that the benefits outweigh the harms. We're just saying that it's realistically, it's hard to get people off of long-term benzos, and most people will not immediately want to come off. And that's okay, because it's kind of a process, kind of like smoking cessation, where we're like chipping away at it. But certainly the benefits do not outweigh the harms in a person like in my case. But again, we're just trying to be realistic about how these things are in practice. I don't know if you want to add anything to that, Rita.
Yeah, I think I have a few colleagues that are new to practice that I've had a chance to talk to about this. And there's certainly a very strong message that we're giving to new practitioners that benzos and sleep drugs are terrible. They're bad. And if you get a patient that's on them, you need to get them off immediately. And what I've really been trying to emphasize with those people is your number one job as the family doctor is to create a longitudinal relationship with that person to help support them with their health for the time that you are connected. And if you make them so scared and angry that they don't want to book another appointment with you, then you're not going to be able to do any of the other things that need to happen for that patient as well. And so really thinking about investing in that relationship so that that person comes to trust you, so that you can have these hard conversations. One of the things that I will sometimes do when I get a new patient who's on these drugs is say, okay, so I have some concerns about this. And if I get like this prickly, like, don't you dare try to stop them, I'll say, okay, hey, we've got a lot to learn about each other. How about in 3 months or 6 months, can I bring this back up again? And that's usually a good way where they can, take a breath. They might say, well, we can, but I promise you, I'm still going to need them. But that's okay. It's given me a little bit of an in, and I can start to work on that. And it may be that that this person needs to be on those drugs, that we're going to try things. I'm sure we all have those patients that you try to taper them off the PPI and they just never can go off the PPI, and you just keep ending up prescribing the PPI. So it's a very similar kind of process. And there's a lot of, I think the other layer is the medical legal concerns that aren't really rooted in facts. In the SOAP note that I included, I made sure that I put reference to all the British Columbia practice standards that refer to sedative prescribing so that you could take those into consideration as well.
I'm just looking. Oh, there's a good one. And you may be better positioned to answer this question, but talking about non-farm and just prescribing practices in people that are precariously housed or have substance use problems, where the usual sleep hygiene practices maybe don't really fit. And these people are more commonly relying on sleep medication. So I think I'm currently in my practice not really facing that. I don't know, Rita, if you have good advice for that.
Yeah, I mean, I think addressing the things that are reasonable to address, like beliefs about sleep. So does this person feel they need 10 hours of sleep, but they're only getting 6, but they're doing okay? That's one thing. As well, do they have a realistic perspective about what the sleep medication might be doing for them? So all of that stuff. But then also, like, until we get a housing solution in Canada, until we rectify the horrible issues with stigma related to mental health and the divide between the rich and the poor, like, let us be realistic about what we can actually expect from people. And so, I think that you need to, if somebody is getting some benefit from having 3.5 milligrams of esopicolone continuously when their life is kind of falling apart around them and they are precariously housed or facing other issues, that makes sense to me. What we want to be doing is we want to make sure that we are not just slapping another harm onto that person, but that we're making a shared decision that is moving them towards the health that they need, maybe just in the short term, maybe in the medium term. I love this question or this comment about sleep issues as a project with the patient and family if there's a child. Yeah. Wade, why don't you say something about that?
Yeah, I mean, I think it just comes back to a lot of the things that have been said in the chat, where like people are, talking about things like screens before bedtime. And I think it's kind of addressing a lot of the different sleep hygiene factors, like, are actually really, really important and sometimes overlooked. So yeah, I don't have, as someone with young children, I wish I could tell my 2-year-old to not wake up at 4 a.m., but not realistic.
It is totally not realistic, but it can be a whole family project. Thank you. Best suggestion for shift workers. Oh man. All the same things within the context of the structure that they've got. So do your very best, do shared decision-making, try to reduce harms from prescribed medications, but realize that they need to get enough sleep to be able to do their life. So we have reached the end of our time, and I'm so grateful for your comments and for the opportunity to share this information with us.